Okay, so we will start the fourth episode of the APAGE-ISMIVS Haifu series. So with me today in the so-called seminar will be my co-host, Dr. Olarik Musigavong. He's a very good friend of mine. You can see him on the screen with all smiles. Yeah, and of course, other distinguished guests will be Dr. Lee Kinwai, who will be speaking soon after this, and also Dr. PM Gopinath, who's giving the third talk, and of course, last but not least is Dr. Herming, who is going to round up tonight's episode. So, without further ado, let me introduce Dr. Olarik. He is presently the head of reproductive endocrinology and surgery clinic in his hospital, and he was also the chair of complementary and alternative medicine special interest group of the American Society of Reproductive Medicine in the US. And he is in the subcommittee gynecological endoscopy and reproductive medicine of the Royal Thai College of Obstetricians and Gynecologists. And of course, Olarik is very active in the arena of fibroids, endometriosis, and also gynae endoscopy. So I would like to invite him to co-chair with me. Olarik, it's all yours now.
Thank you for your kind introduction. นี่ฮาวสวัสดีนะครับ Selamat pagi, right? Okay, ครับ Thank you for your kind introduction. Thank you, Professor Fong Yoke. You are my good friend, my mentor. So he's in the past, he's the head of the benign gynecology at the Department of Obstetrics and Gynecology at NUH. And now he is a senior consultant at the same department. He is the past president of OB-GYN Society in Singapore 10 years ago, and he is the chairman of AO4 of endoscopy committee. And now he is the medical director at the Asta Laparoscopic and Robotic Center for Women and Fertility, Singapore. So please, Professor Fong, over to you. You are mute. You still mute your microphone.
Thank you for the reminder. It's always so nice to see you and have a co-chair with you. So our very first speaker is Dr. Lee Kinwai. He is a very well-known figure in the area of gynae endoscopy, one of the senior founding members of APAGE, and also one of the pioneers of Haifu in Singapore. He has a special interest in the provision of pregnancy care and delivery services, and he is indeed very passionate and highly skilled in endoscopic work, especially in hysteroscopy, laparoscopy, and vaginal rejuvenation. Of course, he has conducted many international lectures and precepted many endoscopic workshops in the region. And in fact, he introduced Haifu, a non-invasive surgical procedure for the treatment of uterine fibroids and adenomyosis. And like I mentioned earlier, he's one of the pioneers to perform Haifu in Singapore. So he also has many past accolades, such as being chairman of the MIS Center in Gleneagles. He was president of the ONG Society of Singapore back in 2003 to 2005. And like I mentioned earlier, he's a founding member of the APAGE. Is Dr. Lee here?
Yes.
Yes, okay. So without further ado, I'd like to invite Dr. Lee to give the talk. He's going to talk about the learning curve of Haifu.
Before it's on the talk, I have to apologize. I'm down with a very bad cough. So, can you hear me? Thank you so much for having my. First, I would like to say tomorrow. Happy birthday, Shillong. And I would like to thank the participants of everyone for this lovely fact. This is from Professor Ashira of the fact. Thank you. Now, my thought is, let me say something as an introduction. Every day in our clinic, we see more benign cases than cancer cases. One. Therefore, learning how to do it. Fibroids and Adenomyosis is important. But, however, in many societies, benign gynecology takes a step behind cancer surgery. Cancer surgery is not the liquidary of the bed. Benign gynecology is the membrane, is the basis behind the bed. Now, I take this opportunity to reveal the idea of Haifu. The first largest American, the first largest American gynecology. The second one is ultrasound. Ultrasound gynecology. And ultrasound gynecology is invented by a gynecologist, one of us for gynecologists. That's why it's important to learn. Furthermore, as all of us are laparoscopic surgeons, women we do surgery for women because less pain, cross recovery, shorter hospital stay, and longer Haifu is a step forward. Most of the time, you can avoid the hospital stay. So, in time to come, just like this one kill surgery over laparoscopy, just they become Haifu is a choice before other forms of surgery. That's why, in my mind, Haifu is revolutionary. Very few people in the world has heard of it. Everybody is talking about it. Everybody is talking about Myomectomy, which is normally done by radiologists, but Adenomyosis is invented for us, the gynecologists. I list down the main differences here. Sometimes efficiency, I believe, is assistant percent. I can blame by any gynecologist or surgeon. Whereas I have it only by intervention evidence. We are using the machine. In ultrasound, the patient is outside on the procedure table, whereas in America, the patient is set into the MRI machine chamber, so you cannot communicate with the patient. All you can do is ask the patient not to move, whereas in ultrasound, the patient is on the bed and talking to the doctor. That is communication. In America, the patients normally heavily sedated. So when the space left out the just no. This is a picture of the so-called hypokinetic APAGE Professor Shilam with on myself. This is Sub-Endometrial Tumors. The Professor Q German. This is a technique you learn. This is来自重庆 China. I have summarized get rid of this. When you write back, Adenomyosis, how do we offset? Is I remember left front of me, left front of me or side of that. You go down the whole world, it's about this way. The surveys, for example, left front of me. For Adenomyosis, you get damage, scar variations, and fear of scar differences. I think Dr. Salva mentioned that the last time. Then the risk of adenomyosis. In adenomyosis, there's so many routes. This is that. There's the finish of the center. Haifu, have a photo of them, but all these things are very surgeon dependent, and they all cause scarring. With the fear of uterus, very often the uterus because it's around Frankenstein like this. The alarm method drugs is the actual embolization. I just look. Fish do nothing and faces wondering why do nothing. You must understand what has changed in gynecology is the women of today is different from the women of yesterday. They are more educated, more independent, living marriage, elderly mother, or she's single. What have we learned? We learned from old surgery, keyhole surgery, which is breaking for the sake of patients. And now we have the two scarlet surgery. Again, how to avoid all this? This is a beginning 1 year after Haifu. As my patient, I cleared my knee and fibroids made by me. The original stimulation after 1 year. This picture was given to me by a surgeon who suggested for other non-gynecological conditions. And I told him after 1 year to keep and I understood and always I see whether they are efficient or not. So I wonder, the fibroid is something in the mirror. Now, Haifu is another ultrasound. The research device is much real time. And I said Haifu, my intervention resulted in not real time. How the drug Haifu is much safer because it's real time and more efficient because it can achieve 600 degrees centigrade. This is Professor on the first department with non-gynecology. This is Professor Westbrook. This is the now I use in Singapore together with Professor Fong for the right and anatomy college. in a hospital setting. The risk of voluntary compared to all the others like laparoscopy, the risk of voluntary is much lower. We have before that no change in ovarian function of the Haifu. The deliveries can be achieved by non-vaginal delivery. This is unpublished data up to December 2020, over 2 years. I have done 118 personal cases. 120 because you, I was repeat until the education by not mixer and the elements. 7 times average about that over to the office. This was my learning curve. One of the is how come they missed not clear? So I put it to the founder, and the founder says, I said some passing to water. Now it's here. This is what it is best machine. MRI image is not lot. So this is right, and you can really separate it. No problem. Can you look here?
Prof, can you hear?
Cannot hear. I can see the video, but no sound.
Anyway, it's speaking in Mandarin. Like this, I got not learn the new English. So, when you get the new machine, you will get the software when the first ultrasound image is clearer. Photo gonna is okay. Basically, what is this is he has got the first the ultrasound image with the MRI image. Give us a better idea of where the target is. Okay, we come to the keys of it. 3 stages of understanding. This was decided by I need the 3 stages. Basically, stage 1 is familiar listening. This is them to find Haifu overseas centers in Hong Kong, Singapore, and Taiwan. The one in Hong Kong and Singapore will be in a minute. After that, the session, you may also bring the nurses along. So you just and that with Haifu something but time where the delegate can do the hands-on. My advice is do your thing too early. Since at the moment you are allowed to operate on your patient. There will come time just like the Western world whereby you cannot touch the patient. After that, you will also get a certificate. This tree is where you go back to your Haifu centers and learn the Haifu special services. So the independent is complete more than half the month. Sometimes I find that first thing is not enough because the first person that comes to are very complicated. For more information, consult APAGE. Education at gmail.com or your local agent. I know a lot of stories on the classification of Adenomyosis fibroids, but to the patient is not important. But there's an extrinsic adenomyosis or intrinsic adenomyosis. It's just like the rust in the cut. Whether it comes from outside the pavement or internal for the engine, is how is the mechanic can do it. So in Haifu is very simple. We're talking about a experience-based method. No more theory, no more different classification for storytelling, no more different classification. Like a Christmas tree, it's measurement can treat or cannot treat. This is what the patient wants to know. No, how do we classify that disease? This is mainly for us doctors to use. To the patient, the classification on the in Haifu, my limited experience is submucous fiber can be done. Intramural can be done. With some good can be done. But not because the fibers drop off in the abdomen cavity. This I was going to show until his first cavity. I don't see it. I see the fiber is sick in some mirror. This was 1990. 9 months post Haifu. In some mirror fiber fifth because some because and I just said it. These are a young patient before step fiber. She want to have the baby. Excuse me. And you mentioned the fibroid. That's out. When you get the clear. She's fine for baby now. No surgery on the uterus. No fear of this. No fear of inside of her. So the clear is much more important in the management of expectation. Don't come to this is a young girl. Even just 2 fiber. One is high voltage on MRI. The other one is hyperintense on MRI. You find that this one will respond better than this fiber. However, on cross-section, there's many fibers and also this is the small matter behavior I was not experienced enough to avoid the risk of religious fiber and risking injury to the intestine. So I undertook this fiber. I had to get after 1 year because I didn't take this enough because of the bowel. Will I relate surgery? I say no. But that's not the surgery 2 years of finger good modified. Her fiber keep coming down. To become something. I call it my wrist research. The biggest fiber. 1 year later. This lady has a fiber at the level of the cervix and uterine body. As she compares solid and walking and standing, I turn her away from Haifu because the father is too near the sacrum and too near the rectum. I see the laparoscopic mechanism, and the fiber is a deep rock from left to right, and the without guts after myomectomy. Her legs solid improved. This is another patient. This is somebody of the uterus. This is anybody. She has a big fiber. I did not do HIFU. I turned her down and over laparoscopy. This is the fiber. This is the lymph. I was afraid if I used HIFU of the bowel and the fiber will drop off in the peritoneal cavity. I was worried of the industries. So I did laparoscopy. Learning Haifu is a new chapter in gynecology. You will learn how to use the color of to assess the vascularity of the fiber. You will learn that by filling up the blood adequately, you can push the intestine away. And all this real time. In American Haifu, you cannot see all this. See what she does. Just touching away. That's when I cannot push that touching away. Like this case, I rejected, I turned down the Haifu. Because this ultrasound pathway will hit the touching foot. This is another case whereby I cannot push the touching away. So I refer to the intervention with the additional ambulances. I found out this patient fresh skin scar because it may interfere with the ultrasound. I waited for 2 for the scar to heal. This patient looked like there's not much serious scar, but what I found underneath, she had a mess. When I saw this, I told her I can't perform HIFU because the mess interferes with my vision. The mess. A few interesting videos that you like. when the patient is asleep, just against the move in. Just the danger of MRI and Haifu, you can't see. When the patient is the body would jump and the focal point will change. So you have to be very careful. That's why the MRI and Haifu, they send it over to the patient. That's one how occurs. This is the folic condition. This is the blood. Once you see bubbles appearing in the blood, usually I do one of two things. Otherwise, element immaterial. Either I set the position of the bed, or I drain the blood and infuse it. New cell line. Even in adenomyosis, you can get raised in this light fiber. It's very nice. There's no falling. It's very nice. Kick up one you oversplit a patient. This work is very dangerous. Even you ask the patient not to move. Like in MRI, they tell you move. So Haifu is revolutionary and disruptive to the work and surgery. Disruptive revolution. Because just like over-cerebral MRI, more women will shoot, not with over-cerebral. You must remember this. Less of this will be you. Remember this picture. The foot is not the musculature. What the English mentions of bad workman bless his truth. The foot is not musculature. It's an instant, unconscionable. The fiber was a myosarcoma, which the moment you cut in the uterus, you already upstate that disease with overload in the musculature. We don't think with this whole everybody uses a bed. No. For what? Is that the condom of the sex? So this for fiber adenomyosis is just misbuilt and my and contract develop. Just again with a double combination with because myself. So clear conventional bipolar restricted devices and really very and use after embolization. The use of a surgical room will help. The use of blood transfusion will some of these cases, like Felix War in Hungary, he adjusted a slave surgery. So he frees up a lot of room and beds for other patients, especially now with COVID. I think everybody should offer Haifu to the patient. If they did, at least refer to the appropriate Haifu development. What makes a good Haifu gynecologist? You have a sense of place, special rotation, cover others under. In the physical of MI, I think episode 3, Professor Fong from Taiwan gave a very nice talk of MI, and he's a gynecologist of that patient, and but a single life. Every time many new skills, many new challenges, You wish you could do ever have a fun substance and cover that outside out of Haifu. But I feel what you it can confirm the little silver of America. The patient who lost the suit will be the one that most simple fiber. Big fiber of big interest. Women who speak single women who want to preserve their older women who want to preserve their family units. Women who come from that way need the versions or aspects of it. Only disappointed with later, but often history. You find your patient as considered like perfect. Just no. Dr. Kusia, Dr. YouTube. I must know every better than you. That's why it's very interesting. And you know the first patient that see are the ones who on the surgery for sleep fiber. It can be a mixture of others. And I think we should know by now. Never labor a woman at all. Even if the woman is very menopause, she has the right to preserve her uterus. So Haifu is not a chicken, not more whatsoever. It's a kind of which is happening. The country research, teaching, learning, and learning. It is a whole new to that demands undivided attention. That is what document and key. For the first provision of the female and fertility, I think Haifu is an excellent alternative. Thank you. Over to you, Shepherd.
So please, Professor Yoke.
My turn now?
Yes.
Okay, let me share screen.
So the second part is the topic of Professor Fong Yoke. The topic is the case study of HIFU treatment in Singapore. So please.
So, yeah.
So before I start, I'd like to say that I still enjoy Dr. Lee's great sense of humor. I like it when he say that the girls consult their busybody. As we all know, some of these patients, they go about asking everybody for opinions and so on. And I think I really enjoyed his last slide because it's full of anecdotes. So anyway, I would like to continue and from where Dr. Lee has left off, and we are talking about HIFU treatment in Singapore. Of course, as we all know, Dr. Lee is the pioneer, and we all know that this is a new treatment for fibroids and adenomyosis. The good thing is that this is non-invasive, non-surgical, the day procedure, very little or no downtime at all. And the patient, I literally tell them that they can actually the next day jump off the bed and start walking, running, because there are actually no surgical scars on the abdomen. We all know how HIFU works. I think that has been explained by Dr. Lee. We all know the benefits also, and it takes about a couple of months for the symptoms, and then of course we know that the fibroid will shrink over time, and its literature has reported the shrinkage is up to 70 to 80% volume reduction over a period of 1 year. Okay, now let me go on to this. Okay, so I just want to go on to the development of HIFU in Singapore. we started off in 2018, and this was the installation of the Haifu setup at the Farrer Park Hospital Day Surgery Center. To date, the total number of doctors who have been trained in Singapore is about 12, and the total number of doctors who have performed the procedure is about 10. So it's quite a good uptake, and which means that the penetration of Haifu is quite acceptable. The total number of Haifu procedures done up to this year, December, is 173. In terms of gynecological procedure, of course, Dr. Lee is the most number of cases. If we are looking at the breakdown of cases, then fibroids, we have 115. For adenomyosis, we've got 44. For both adenomyosis and fibroids, we've got about 10. And then 4 others, which included patients with liver and pancreatic cancer. So don't forget that Haifu can also be used to treat symptomatic advanced cancer. So besides fibroids and adenomyosis, this is also an adjunct to treating malignancy as well. So far, in all the cases that we have done, there have been no skin burns reported. In terms of total serious adverse effects, there was one, and this was a patient who reported a L4 nerve root radiculopathy. Basically, she complained of foot drop after the procedure, but she had complete recovery after 3 months, and she's back to playing badminton and moving about and so on. We've had a total number of 6 pregnancies after Haifu, of which 3 came from fibroids and 3 came from adenomyosis. And of course, we also need to know the number of repeat treatment. And so far, there have been 3 patients required repeat treatment. Now, we were doing quite well. If you look at numbers, we had 173 up to the end of December 2020. And all of a sudden, there was actually a MOH review, and in the year of this year in January, they came out with a guideline. We stated that Haifu should be considered an experimental procedure based on the NICE or NICE guidelines, and instead, the category stated that ultrasound-guided Haifu should be done in the research or clinical trial setting, but at the same time, they were comparing ultrasound with MR-guided Haifu, and they actually stated that MR-guided Haifu, on the other hand, has sufficient evidence on the safety and efficacy to support its use as a clinical service. Of course, I will go into a bit more details into the NICE guidelines later on, just to dissect what is the difference between MR guided and ultrasound guided. But of course, with this guideline, it had a big impact. If you say that this is considered experimental, then there are a few implications. It means that we can no longer offer it as a clinical service, which means that there's an immediate stop to Haifu in Singapore after having done over 170 cases. So there was an appeal to MOH, and MOH had a look at the evidence, and of course the audit of the cases was provided to MOH, and therefore they came out with a revised guideline in May 2021. Under the revised guidelines, Haifu can be allowed under certain constraints, but it is not MediSafe or MediShield claimable, which means that the patients cannot use their own so-called Medicare savings in their own accounts, nor can they actually claim from the insurance. Now, this will make Haifu in Singapore very formidable to perform, because as we all know in Singapore, there are rising costs, and of course, any hospitalization is expensive, and to ask the patient to solely bear the entire cost themselves is probably a near impossible. So therefore, there was a big plunge in the number of cases, And so far in the year 2021, this year, we had only 2 HIFU cases done so far. So from averaging at least from over 60 cases a year, now we are down to 2 in this year. That is not a very good sign. The evidence, this can be submitted to MOH, and there can be a review of the guidelines again. The most important is, of course, the issue of the insurance claim. And once you say that you cannot claim, it is, like I said, near impossible for any patients to go ahead with the procedure, because it will be all out of pocket. But with this, I'd just like to go through some case studies on why I have done
Hi, Dr. Yoke, are you there? Can you hear me? Anybody can hear Professor Fong?
why I've embarked on Haifu and why I think.
No, we cannot hear.
Dr. Fong, there is some internet problems.
Sorry, how much of the talk was missed just now?
Just start the case. Just
started the case. Okay, sorry, I had a drop internet connection.
Okay.
So okay, let me just go back to this one here. Can you all hear me now?
Yes, of course.
Okay, can see also?
No, not yet.
Cannot see.
Cannot see the slide yet. Cannot
Oh really? See. Okay, wait. Sorry, I must. I need to share screen. Sorry.
And of course, during Professor Fong talk, you can put in the chat box about your question or idea. So please join.
There's something wrong with the internet connection.
It's okay. It's okay. It's okay. It's okay.
Can you still hear me?
Not yet.
Okay. Get this. Okay. Then I'll go to this. I will share screen again.
Okay.
Okay. Can you see now?
Yes. Yes. Of course. So please.
Okay. All right. Okay. So, case study 1. This was my very first patient actually. She came with a past history of having had a laparoscopic myomectomy in 2009 of a 6 cm fibroid. And when she came, she presented with abdominal fullness. And when I felt her tummy, I had a bit of a shock because there was a big mass, about 20 to 22 week size in the abdomen. When I did the ultrasound scan, I found there was a 13 cm anterior intramural fibroid, as seen in this picture over here, right? It's actually pushing the uterus right to the bottom here. So of course, intuitively, I offered her a surgical option. I said, we can go for myomectomy or hysterectomy. But the patient actually insisted on trying for HIFU. She had read about HIFU. She doesn't want to consider surgery at all. And because of the size of the fibroid, I felt that it was fair to offer her something instead of not doing anything for her at all. So we went on to progress, for the HIFU. So if you look at this, This was the pre-operative Haifu, MRI picture. This is before Haifu. Here you can see this is a big anterior fibroid. It's actually pressing on the lumbar spine, and it's actually above the level of the umbilicus as well. And the Haifu was done on 18th of October in 2018, and we did an MRI the next day on 19th October. You can see straight away that there is a shrinkage of the fibroid. There is actually a space between the uterus and the back of the spine now, right? And the dark area here, this is the non-perfused volume of the fibroid. Okay, so you can say that the patient had a very positive outcome result from the Haifu treatment. But this is the next day, what happens to her in the long term. Now, as we follow her up, then she related to us that she tolerated the Haifu well. There was no significant side effects, no skin burns. She straight away reported improved energy levels, probably because a significant part of her energy stores were actually going to the fibroid, to feed it and to keep it viable. The patient is now 50 years old, and she's actually perimenopausal woman, perimenopausal status. And I just did an ultrasound scan for her earlier this year, and the fibroid is about 7 by 3 cm, right? So I think this is a much more manageable size, and I will be happy to just manage her expectantly and just continue to follow up. With the menopause, then there may be a chance that the fibroid might shrink even further, but at least we know that that will not grow. So I must say that for my first patient, it was a very satisfying outcome. That gave me encouragement to offer Haifu to more patients. So I will talk about the second case study. Now, this patient is a bit different. Now, she is a young girl, she's single, she's nulliparous, and she presented with heavy menstrual bleeding and also urinary frequency. Now, again, when I saw her, once she was lying down on the bed and I had an ultrasound scan, I had a big shock because this was a huge posterior wall fibroid, occupying the entire part of Douglas and pressing on the sacrum spine over here and pushing and elongating the uterus anteriorly. So my scan revealed that this was a 12 by 7 cm posterior wall fibroid. So even before considering either Haifu or surgical option and so on, I decided that the first option is actually to try to shrink the fibroid. And then we can discuss about what is possible and what's not possible. So I gave her a GnRH injection. And this is the picture of the fibroid after 3 months after the GnRH injection. So number one, you can see that it has shrunk very well, right? It's away from the sacrum now. There's a lot of space. This fibroid is probably maybe about 7 cm in diameter. And therefore, at that point in time, I felt comfortable to discuss with her the role of lab myomectomy versus Haifu. At the previous size, I felt that it was I wasn't very comfortable with offering her laparoscopic because it was very, very big and it extended the whole length of the posterior wall of the uterus. So once it shrunk, this was a more manageable size. And she opted for Haifu, which we did towards the third quarter of last year on 28th of August 2020. Now, this is the post-Haifu MRI, and you can see there's a good treatment area. The non-perfused volume is over here. So this was actually, again, a very good result with a large treatment area of the fibroid. Okay, so again, we need to follow up on the patient to see what's happening after the GnRH analog wears off. Is the fibroid going to grow back in size again? Is it manageable? What should we do for her? So I've seen her up to April this year, And if you look at the fibroid, you compare and see. Now, this was the pre-operative, pre-GnRH ultrasound. And you can see this is a huge posterior wall fibroid. Now, this is the current ultrasound, right? If you look at the uterus and you look at the shadow behind the uterus here, it is now about 6 by 5 cm, right? If you look and you compare, it is a very manageable size. So for this patient, we have bought her time, right? If, let's say, for example, it continues to grow again, then of course we will have to consider role of either repeat HIFU or the role of also laparoscopic myomectomy if it continues to grow in size. So I think these are the options that we have for this patient, and we will be, of course, looking forward to see how the fibroid will behave with time. Now, the third patient is a patient with adenomyosis. Now, she's 31 years old, she's in marriage, she's one child, and this was delivered via LSCS about 2.5 years ago. She presented with heavy menstrual bleeding and severe dysmenorrhea. And of course, when we examined her, this was a 12-week retroverted uterus with a very significant bulge in the posterior wall. So you can see here, this is obvious adenomyosis. There's no doubt about that, right? This posterior part here is giving her quite a lot of problems in terms of bleeding and also pain. So because she was young, we discussed, and of course, we talked about HIFU, and the patient actually opted for HIFU treatment. The HIFU treatment was done on the 22nd of August 2019. You can see here the post-HIFU treatment area. Not a very big area, because the area by itself was maybe about 4 cm across. Okay. Now, for this patient, post HIFU, she still had persistent pain. The dysmenorrhea was not completely resolved, and the heavy menstrual bleeding was still persistent. And therefore, we had to supplement with other forms of hormonal treatment, such as Rizan and the DMPA and norepinephrine. But despite giving her supplemental hormonal treatment, she still had persistent pain. And she was on the verge of giving up, and she was talking about the role of hysterectomy and so on. And then all of a sudden, she had a positive uterine pregnancy test on the 9th of November 2020. And then she was confirmed to be pregnant. She went on to have a successful delivery by another colleague in July 2021. So she was started on the progesterone-only pill for contraception. She's breastfeeding, and when I last saw her about a month ago, she had no menses yet, but no pain. Of course, she's quite comfortable now. And when I did the ultrasound scan for her, to me, it does look a lot better than the pre-pregnancy big adenomyotic bulge in front over here. Right? Again, for her, it will be expected management for now. She will probably need some long-acting progesterone method for future control, such as maybe the Mirena or something like that. But it just illustrates that for patients with adenomyosis, we can still buy them time. We possibly can improve to some degree the chance of fertility for them. And in doing so, of course, this again leads to more option choices for the patient. Now we come back later on, when we talk about the size of fibroid and adenomyosis, often people ask when we start treating them. To me, I think I adopt a general measure of about 3 cm and above. The size can be actually up to maybe about 13 to 15 cm, just as illustrated by my first patient, which was about 13 cm length across. Of course, the bigger it is, it equates to a longer treatment time. And sometimes this may equate to repeat treatment if it's necessary. It all depends also on the position, the site, the number, the tolerance of the patient actually, whether she's responding well during the HIFU treatment. So for example, like Dr. Lee said, if the patient keeps on responding to pain, keeps on moving, she's got hiccups, or she's too heavily sedated, then sometimes it may actually slow down the treatment. Over here, we also practice pre-Haifu positioning. That means we actually try to simulate the treatment process before the treatment itself to see whether they are suitable and whether to go ahead or not. So this is to mimic what was mentioned earlier on. Both younger patients and, as I illustrated, even older patients can consider Haifu as a interim step before they experience menopause. Those who are keen to conceive, or those who want to avoid surgery, or even those who have got type 3, 4 fibroids for infertility and you don't want to do surgery. I feel that Haifu treatment, of course, has a potential to be an alternative treatment option. It definitely brings about convenience and benefits to patients. It's got a decade-long history of treatment, at least, with thousands of patients and multi-centers globally. And the local development is a disappointment, to be frank. And I feel that more can be done by our societies as a whole, both APAGE and APAGE-ISMIVS. They can help us to overcome this barrier. Now, if you look at the NICE or NICE guidelines, and this was a comparison of the guidelines. EMRA was actually last reviewed in 2001, and this was actually more recent in 2019. And where it clearly states that for EMRA guided Haifu treatment, there are well-recognized complications, but the evidence of safety is adequate to support the use of this procedure. Whereas for ultrasound, it says that here it should not be regarded as a definitive so-called treatment, right? Because it says that there are well-recognized complications, including skin burns, and therefore they say that this procedure should only be used with under special arrangements, and that's the current constraint that we have in Singapore now. Looking at the evidence that we have for EMRA guided Haifu and ultrasound guided Haifu, if you look at this, the overview, the review done for EMRA Focus in 2011 was based on about over 800 patients. And then the ultrasound Haifu was based on 28,000 patients. I mean, it's a big difference here. Both reviews carried one, no, in fact, okay, so the EMRA review actually didn't carry any randomized controlled trial, whereas the ultrasound carried one RCT, and you can definitely see that it carried 4 non-RCT, whereas the EMRA guided review had only 1 non-RCT comparative study, right? So I feel that to label ultrasound guided Haifu as unsafe because of skin burns is a little bit unfair, right? So I hope that, of course, the societies can help, and also probably maybe write in and be persuasive in the argument on the safety for ultrasound Haifu, even to the so-called the NICE committee or the UK guidelines. So if that, I end my talk. I'll be happy to answer any questions. Thank you very much.
Thank you for your very informative lecture. Always like your lecture. So if anybody want to ask the question, please raise your hand. We can do like a one short questions. If there is no question, I will ask. So do you have the experience about the post treatment of the Haifu? Are there any adhesion, or there's anything you think is it the complication from the Haifu?
I think the main issue that we are concerned about will be safety. And if you look at the MRI, post-MRI pictures, you have a good margin of safety. So I always tell the patients that we're actually treating the core of the fibroid, and you're actually leaving a rim of fibroid tissue around. That will make it actually very safe. Yeah, and in fact, you are actually not targeting normal myometrial tissue at all. You're only targeting so-called abnormal tissue. Now, we compare this to adenomyosis. If you want to compare the role of adenomyomectomy versus HIFU, personally, I would feel that HIFU is even more favorable because, first of all, there are no cuts on the uterus. For adenomyomectomy, if you remove too much, you will have problem with scar dehiscence. If you remove too little, then it's not worth doing it at all. Then you might as well just do the HIFU procedure for them, and then see whether the outcome will be good for them or not. So I think most of the so-called HIFU, if you keep it localized to the target area, it should be very safe. Adhesions, we won't know, but it's very unlikely. Yeah.
Thank you. So now your turn to introduce the next speaker.
Okay, so of course we have our next speaker, and he is Dr. PM Gopinath. He's going to talk to us on fertility and pre-treatment of uterine fibroids and adenomyosis. He is he's the director and senior consultant of the Institute of ONG for Medical Science in India, and he has performed many cases, and he's a specialist in both hysterectomy, laparoscopy, hysteroscopy, even microsurgical tuber anastomosis, and he's also dealing with infertility and expert at the IVF. He is currently a member of the European Society of Human Reproduction and Embryology. He is also an elected member of the American Society for Reproductive Medicine, and he's a member of the International Fertility Preservation Society. He's the founder secretary, IFS Tamil Nadu branch, and he is the deputy head, the medical group of endometriosis management of the Shanghai Medical Association. Over to you, Dr. Gopinath. Is he there?
I'm here.
Oh, okay, good. Yeah, let me take over.
Okay. Can you see my slides?
Not yet.
Can you see my slides?
No, still not yet. Yes, okay, we can see now.
Fine. Thank you, chairpersons, and the societies for having invited me to share some of my views. So I'll be talking to you on pre-treatment of fibroids and adenomyosis. You know that we have started on an IVF in 1978, and then from then on about 40 years have come. Even though you will see here, the Louis Brown's has got his own child. The second generation has come. But however, our results are not very great. It has been only about 20 to 30% all through. And mainly it depends upon the age of the patient and the ovarian reserve, male factors, stage and grade of the transferable embryos, uterine environment, luteal support, and additional risk factors. So when you focus it on the uterine factors, you will see that it depends upon the size and shape of the cavity, endometrial lining, blood flow, receptivity, myometrial support, mainly presence or absence of fibroid and adenomyosis. How does this fibroid affect?
Excuse me, Dr. Gopinath, your slide is not moved.
Now, my slide is moving here for me.
No, but for me it doesn't move.
One minute, I will stop sharing and share again.
Okay, please.
Is it visible now?
Yes, yes.
Yeah, this is infertility and myoma. It is very commonly seen in IVF patients because there is a delay in childbearing when fibroids become more common. Also, the age decreases the fertility. There is some encroachment of the tubal ostium, distortion of the cavity, vascular changes, interfere in the rhythmic contractions, impaired implantation, abnormal endometrial maturation, and alteration in oxytocinase activity. So when you see the normal uterine cavity, there is something like called cavules in the host myometrium. So this number of cavules are decreased when there is a fibroid. Because of the structural changes, there is an increase in intracellular calcium. If there is an increase in intracellular calcium, it produces myometrial irritability that results in the disruption of the rhythmic contraction of the junctional zone, which is very responsible for implantation there. What about the sub-endometrial tumors? They're causing the erosion, subsequent inflammation, and they disrupt the endometrial blood flow and affects nidation and subsequent early embryo. If you look at this review by Jacques Dones in 2004, he has seen the impact of myoma on infertility when it is distorting the cavity and then there is no distortion. You will see in this study, there is a distinct reduction in the pregnancy rates in a patient who has got the distortion of the cavity with this fibroids there. And this is again another important PRIT study, which consists of about 3 prospective and 8 retrospective controlled studies, where they concluded subserosal fibroids do not affect the fertility or spontaneous abortion rate. Submucous fibroid lower the fertility rate, and myomectomy enhances the rate of conception and live birth. Intramural myoma with or without of the cavity may have caused detrimental effect on reaching the viability of this thing. Effect of myomectomy is not clear. And if you look at the submucous fibroid, when it compared to the control, the clinical pregnancy rate comes from 30 to 14%, and the spontaneous abortion rate goes from 21% to 46%. So that means definitely it has got an impact. And the effect of myoma, when you see an intramural myoma, there are conflicting reports. Some of the papers saying that it negatively affects IVF results, and some of the papers says that it do not affect the IVF results. So in total, when you just see the implantation rate, if it is there from there, it stops from about 20.2 to 11.2, and pregnancy rate drops from 34.1 to 23. Ongoing pregnancy is dropped from 28 to 15%. So a large intramural myoma negatively affects the pregnancy outcome, particularly when it is more than 5 centimeters. And again, when it is larger than 5 centimeters, it definitely has got an impact. But that doesn't mean you cannot go on performing this myomectomy in a woman who is not coming for an IVF, because by doing that, there will be an excessive adhesion formations there. What about the fibroid, which is less than 5 centimeters? Should be, you have to disregard it. Do we operate before IVF? Should we operate after IVF failure? And if yes, for after how many failures? Should we operate before any infertility treatment? Should the decision be influenced according to the cost of IVF in different countries? These are all the questions which comes into the mind when you're dealing with a borderline fibroid. But however, when you look at the studies, they say that there is no difference in implantation rates in pregnancy when it is smaller than 5 centimeters. And another publication in fertility study says no effect in pregnancy rate and there is no miscarriage rates. So the small fibroids, when it is less than 5 centimeters, you will see that in a control, it is about 32.9 against the pregnancy rate of around 29 in another study here. So overall, when you take an ART, the ongoing pregnancy and the live birth are reduced in an ART by 40% in the successive cycle. So that means if you want to improve your IVF rates, you have to go in for an intramural fibroid removal in whichever form which is comfortable to you before you plan for assisted reproduction. Here again, the study, you will see that the results of clinical pregnancy rate in a patients without myoma, it is 41%, and with myoma, it is about 34%. You look at the number of abortions, it is about 18.9% without myoma, whereas if myoma is there, it goes as high as about 40%. So this is again looking at the number of fibroids. If you see the second column, it is less than 3 myomas. Third column is more than 3 myomas. You will see that the number of abortions is about 34.3% if it is less than 3, whereas when it is more than 3, it goes as high as about 60%. This again shows the importance of treating myoma before you go for an IVF. You look at the pregnancy rate after an IVF here in an intramural. So in different studies, they have just compared it with the control. It is much less than that. All this, the pregnancy rate is much less than the control. However, you look at the miscarriage rate is much higher than the control in all the studies. So this is to just say, you have to go through some form of a treatment before ART. And then what about the implications of a myomectomy? This is a Dubison trial which just says the importance of adhesions and then adnexal adhesions here is very high, both with laparoscopy and laparotomy. This is a region where we just contemplate on the thing. But now coming to the problems in the management, one is the cost of the treatment of fibroids and adenomyosis adds. And there are some aftermaths of the treatment, scarring and then poor vascularity, time taken to heal and be ready for the embryo transfer, patient's emotional stress, results of the embryo transfer after the treatment of a fibroid and adenomyosis. All this are the problems with this. What about the adenomyoma? Most commonly seen in IVF patients because of the delay, and also there is an increase in age. So this is the junctional between the outer and inner. This is the area where we see the junctional zone. This is very important because it has got a series of changes and it is a functional important in the entity in reproduction. Oncogenetically, it is related to the endometrium. Cyclical changes here has been affected, and the role of gamete transport and implantation takes place here. Early changes from time of implantation is very important here, and decastellation and the trophoblastic invasion takes place in this particular junction. If there is a defective transformation of this junctional zone spiral arteries in the spectrum, it can result in any of the complications there. So junctional zone by itself is very important, and it exposes the embryos to a higher junctional zone activity as a consequence of high hormonal levels due to the controlled ovarian hyperstimulation, uterine manipulations during the IVT. So if there is an abnormality of the junctional zone as a result of adenomyosis, the implantation definitely comes down. This is to highlight the various junctional zones. And this is what we mean by the endometrial. This is a normal junctional zone, whereas it is uniformly higher where it is a global adenomyosis, when there is a focal adenomyosis in only one place. This is how it looks in an MRI and all these areas there. On a transvaginal ultrasound, it's an asymptomatic uterine enlargement, and it is a globular appearing uterus. Between the transvaginal and MRI, MRI is more sensitive and then gives you an accurate diagnosis there. What happens when you do an ART in an adenomyosis? Number one, few follicles and poor corpus luteum, M2 oocytes with scattered chromosomes here, cytoplasmic fragmentation, formation of a pseudopronuclei, and spontaneous oocyte activation occurs, reduced fertilization and abnormal nucleoli, delayed and arrested embryo and cleavage, no microtubules in the blastocyst. So, and what happens when there is an adenomyosis in an oocyte donation program? You will see here, when it has been compared with the low responders, it is again poorer, and then you can just see the term pregnancy rate is about 22 when compared to 33 as per the presentation in an estuary. And here there is another Bernhardt analysis here. It says significantly lower pregnancy rate when you compare to that of a tubal factor in infertility in the case of adenomyosis. Again, the same way, when you look at the endometriosis, 3 and 4 had a much lower pregnancy rate when compared to 1 and 2. So implantation in ART is mainly on the embryo quality, transfer efficiency, and endometrial receptivity. Whereas in an adenomyosis, the endometrial receptivity is completely lost there. When to offer IVF? Does it affect the IVF outcome? Is medical treatment is useful? Should ICSI always be done? If the surgery is needed, when to offer and which technique is the most crucial decisions here? We all know we have just started with the medical, surgical, combined medical and surgical, came to the ablation, then MRI focus. My previous speaker has beautifully put up the difference between the MRI focused and an Haifu ultrasound, and then brought out all the evidences there. Meta-analysis says that there is absolutely no great improvement in the medical management before the RCT. This is an historical study from the surgeries from Osada, where not many Osadas are arising in the universe today to handle this. And you know, whenever you do a surgery on an adenomyotic, you will have a lot of difficulty in covering it when you do it both in a laparoscopy and also open surgery. It is something like cutting a guava fruit and then enclosing both the structures together. It will be really difficult and challenging there. MRI has evolved. It was been for, but now somehow or other, the instruments are not being that common in my place, where I had a training in MRI focused ultrasound. We were doing it. Then now it has just come to the Haifu, where it gives you a lot. The professor who, with all his handicap, has beautifully put out all the points for a Haifu, and why he mentioned it. It has to be just covered at the current day, even though we have all the other adjuncts here. And if you are going to go in for an ART, both for prolapse and also for both for the fibroids and adenomyosis, you have to think in terms of that. You know, even after an adenomyosis, if she becomes pregnant, there are a lot of issues, like, you know, it is highly risky. There will be a miscarriages, and you should avoid sharp curettings there because it enhances. But however, sharp curetting and non-pregnant does not enhance us. To conclude, fibroid and adenomyosis are enigma to the ART personnel. There are definite evidence to say that they decrease the pregnancy rate and live birth. The miscarriage rate is higher than the control. Their managements are confusing and invasive. There is a need for a novel, minimal invasive, cost-effective procedure to tackle them and improve the pregnancy rates in an ART. Probably, I think we have arrived at an answer with way of IVF before and Haifu has to be done. Thank you very much for your patient listening.
So thank you very much, Dr. Gopinath. So I'd like to ask if anybody has any questions to ask. You can write it down on the chat. If not, then I'll first start off with my own question. Where do you see the place of Haifu in the management of infertility? Since you said that you have had training, but you haven't done any cases so far, and what is your prediction for the role of Haifu versus so-called standard laparoscopic surgery?
Fine. See, basically I was a open surgeon, then switched over to laparoscopic surgeon, and then did an MRI focus, and then had a training. So I can go through the pass through the generation. If you see a fibroid or an adenomyosis in a patient, young patient who is coming for infertility, I would, if they are going for an ART, I will stimulate them, pick out the oocytes, create the embryo, preserve them, then take them for an HIFU, and then after the reduction, and then probably after 3 months to 6 months, I will go for a transfer. This will be my answer to your question, sir.
What if they haven't come for fertility yet, but they say that we are thinking about trying? So what would be the role then, if you see such a couple?
Yeah, if you're asking about a non-ART couple with infertility coming with the fibroid, as we have mentioned it, the size, number, location plays a very important role. Based on that, if I have an option to do an HIFU, I will very easily just go for an HIFU, and then after 3 months, plan for the treatment directly.
Okay, thank you very much.
Thank you.
Thank you. Olarik, shall I leave you to introduce the next speaker, last but not least?
Yes, last but not least, and this is very important. Our speaker, Dr. Min, she is a director of a training department, Engineering Research Center of Ultrasound Medicine in China. She is the senior training lecturer of Haifu training based on China, and she is one of the lecturer of the ISMIVS, International Society of Minimal Invasive and Virtual Surgery. She is more successfully more than 4,000 cases of a benign malignant tumor treated by HIFU. So please, Dr. Min.
Okay, can you hear me?
Yes, of course.
Okay, thank you for introduction. I'll share my PPT.
Yes, now I can see.
Okay, can you see my slides?
Yes, yes, yes.
Okay. Thank you so much. I'm honored to have this opportunity to share some very interesting cases and maybe some difficult for a lot of primary doctors for HIFU. The mechanical of HIFU, how HIFU treatment works, our professors have talked a lot. So what do we want from HIFU? During the HIFU, the most important thing is that the safety, the treatment safety, and the second one is effectiveness. And also we want to do this very quickly. That means efficiency. But for now, we focus on the first two parts, the safety and the effectiveness. So what are the factors affecting HIFU treatment? For the patient, the first thing is a BMI. If the patient is a little fat, the abdominal wall is thick, this may be cause some difficulty for us. And also the position of the uterus, the number of the fibroids, the position of the fibroids. Also the blood supply, the intensity on T2. This the factors will affect our treatment efficacy. So today I will give three types. Three types are very interesting type in our treatment. The first one is this posterior uterus. This type means that the position of the uterus affects our treatment, and let's see how this affects our treatment. You can see this patient from the MRI. This is a central T2. We can see this is a posterior, the position of the uterus is posterior, and here is the adenomyosis. For this kind of patient, it's very difficult for us to treat. Why? Let's see. So for this kind of patients, what need we pay attention to? The most important, the first thing is the safety of their QC pathway. Then include the abdominal wall and the bladder, which help us to set safer QC pathway. And also because the position of the adenomyosis, this patient during our treatments, she would feel psychological pain, and also we need to pay attention to the radiation pain, and I need to control the energy. That means we don't give too much. We don't give too much, because for this kind of patients, for this our new type classification for this adenomyosis patients, this is we need to control the energy, because we need to protect the uterine cirrhosis. So let's see this. This is a persistent before HIFU treatment. We can see the bladder is very big, and it's just the tension is very high, and we can see the focus. The focus is just on the boundary of the adenomyosis. That means we cannot put this focus in the middle of the adenomyosis. So for this kind of patients, what should we do? We ask our patient to do some bladder training. This picture is 5 days later. The patient do some bladder training, then come back. We can see the bladder is changeable, and the image is very clear. It's much more clear. And on the focus, we can put the focus just in the middle of the adenomyosis. So we can see the acoustic pathway is very safe, because all of this is through the bladder. The bone is in front of the, is just outside of the acoustic pathway. And for this patient during the treatment, our doctor do try something. We can say we know that we always can use water balloon to push out the balls outside the acoustic pathway. So they tried. The first picture we can say is just under the bladder, a little to the head side, and we can see the boundary of the uterus. And for the second one, they change it. They change the position of the water balloon, and we can see the boundary of the uterus, but also the uterus is very close to the rectum. So under this situation, the patient felt very, very pain. And then the third one, they just move out the water balloon for the water, and we can see the acoustic pathway is safe, and the focus point is in the middle, and also the boundary, the uterus is a little away from the rectum. So the patient's reaction of the patient is much better. So for type 1, the posterior uterus, we need to do one thing. This is most important thing is bladder training. Bladder training can help us to build a better acoustic pathway and reduce the reaction of the patient. Now, for this is the contrast enhanced ultrasound image. This is before. We can see the microbubble is in the adenomyosis, and for this part is after HIFU. After HIFU, we can see there's no bubble here. So second type, this type is very important, and a lot of doctors think it's a little headache. Let's should see the video. A lot of fibers here. Even we don't want to count how many. And after HIFU, we can see all the fibers are just necrosis. There is no blood supply here. For this one, maybe we can, we think this is easy because it's just all the fibers are just in the pelvic. And let's see this one. Too many. A lot of fibers, a lot of big fibers here. You see what kinds of fibers? And after the sonication after HIFU, most of them, almost everyone, only one at the right side. So here, for this one, this big one, this big one, this big one, and a lot of small fibers here. This case is very interesting because during the treatment, we only treat 5 fibers, but the necrosis part, fibers is more than 5. You can see here, for this patient, for this kind of fibers is the most difficult one for us. And we only make 5 plans. The first one we treated is anti-cervical myoma, and the sonication power is 400 watts, and the sonication time is 1 to 3. And we give several cycles, and the patients can tolerate the treatments very good. So we adjust the power to 400 and 2 to 3. When we give 33 seconds energy, and there is great scale changes here, and we reduce the sonication time to 1 to 2. And for this first one, we give 478 seconds time. And then the second one is the anterior and the anterior one. And for this patient, because it's high level, that means it's close to the spine. So after the first fibrous treatment, we just reduction 100 of the bladder, 100 millimeter of the bladder. Then we can lower the uterus, and then we start from 400 watts 1 to 3, and then we improve it to 4. And after 25 seconds, there are great scale changes here too. And for these fibers, we only give 249 seconds. And then we treat the third one, that is anti-founders. Anti-founders, and for this kind of, for this one, we only give 149 seconds. And during the treatment, the patient feel a little, several times of skin burning because of the belly here. And the fourth is at the right central muser. And for this patient is for this fibers is very high, and we empty the bladder, and we give 260 seconds. And then lastly, we treat the fifth one. And for this one, we because 30 seconds, we have great scan changes, and the patients cannot service is very good. So we just reduce the power to 300 watts. And for this one, we only give 68 68 seconds. So the total certification time for this patient is only 1,204 seconds. So we go back to see the video. We only treat five big ones, but we have more than 5 fibers. We have a lot of fibers that have necrosis here. This one, and for this one, this is the first one. We can see this small fibers. This big one we treated, this one we treated. So for this patient, she gave us some surprise, a big surprise. So what need we pay attention to this kind of multiple big fibers? The first thing, the most important is the safety of our acute pathway from the abdominal wall. For this kind of big one, the belly button is a risk for skin burning, and also the bladder. The bladder, that means maybe we need a small bladder, or even we don't need any bladder. And also for this kind, because the fibers, the uterus is very big and is close to the spine, so the radiation pain is a high risk. And for the multiple fibers, the key factor is that we need to increase possession of every fibers. We need to choose which one we are treating, which one we will treat. So I tell our new doctors, for the multiple fibers, we need to make a very good treatment planning. That means identifying treatment goals. That means which ones we are going to treat, and determine the treatment sequence, because we have a lot of fibers. Which one we treat first, which one is second. This is very important. And then we need to make treatment particular plan for every fibers, because every fibers is different, the predation is different, so the acoustic pathway is different. This picture you can see, I always ask our new doctors to draw pictures just like this. We just do some very simple one. This is the uterus, this is the bladder, and the abdominal wall. And this one give you some tips before you make the plan. And this one is just a single one. But if we meet with a lot of multiple one, so for multiple ones, we always draw 3 slices: the mid one, the left side, and the right side. And we draw the circle here. That means there is 1 fibers, and we numbered it, and then we know how many fibers are there, which one we need to treat it first. For example, for this kind one, the 1, 2, 6, 7, 10 is in the posterior wall. And we need to follow the principle of the treatment. That means we first treat the deeper one and then the shallow one. So the first one we need to treat is the number 1 or number 6, and then the number 7 or number 2, and the next one is the number 9. So this is the plan. This is our plan. And also for this one, we need to, the first fibers we need to treat is number 4. Okay, the third type is also a very interesting one. For this one is a 43 years old patient. Before HIFU treatment, she is very pain during the period. The VAS score is almost 8, and then she don't have the courage to keep her uterus. So she come to me. We can see that there is adenomyosis in the posterior and also a lot of small fibroids in the front. And also there is a chocolate cyst. And I asked her to come to me. I think I will have some method to solve her problem. And this is our treatment. So we can see the video. This is before fibroids and adenomyosis. And also this is very, very stick to the rectum here. So we can see from the MRI that the posterior wall is very close to the rectum. It's very serious, it's sticky here. And for these patients during menstrual period, the patients even don't want to eat anything because she feels so pain. She even don't want to go to toilet. And for these patients, give me some surprise because I don't have any expectation for the reduce of the of the pain during the period. But fortunately, after 2 days after the HIFU treatment, here there was her period, and the VAS score is only 2. And we gave her 3 periods of GRH, and then 3 months later, she came back, and we gave her and we performed our laparoscopic surgery for the adhesion, and for the chocolate cyst. And now the treatment is going on. We give her another 3 periods of GRH. So what need we pay attention to this kind of patient? Also, the most important thing is the safety of the HIFU treatment. And for this kind of patients, because the adhesion of the posterior wall to the rectum and is very close to the spine, so she will feel very pain, and during the treatment and the radiation, and the radiation pain is very serious. And also for this kind of patients, the energy control is very important. If we give too much, maybe there is just the uterine cirrhosis is broken. That's very dangerous. And also for this kind of patients, is if we only give her HIFU treatments, there maybe the symptom will relax for a period, but won't last for long. So we give him combination treatments. That means we do HIFU first, and we give a 3 period of GRH, and then laparoscopic treatments. And 3 months later, we will give her or place our urine. So do some summary for HIFU treatments for the patients. The most important one we see that we need to give individualized clinic treatment plan. Every patient is different, and during the treatment, every fiber has its own acoustic pathway. That means we need to build individualized acoustic pathway, and also every fiber is different. The blood supply, the intensity of T2 is different. That means every fiber has different doses. So, and during treatment, we must remember everything can change. We need to change. Thank you so much.
Thank you, Dr. Heymin. So, are there any questions from the audience? So if not, I have the question. You are the great teacher. You have the student all over the world for now. So my question is, what is the most important skill for doctor who want to do the HIFU? For example, for the laparoscopist, I think one of the most important skill is eye-hand coordination. to do the surgery. So, and how about the HIFU? What is the most important skill that we need?
Thank you so much. I think for HIFU, it's not very, sometimes a lot of doctors come to us, they think HIFU is very simple. Why? Because they think we just sit from the computer and click, and maybe we can listen to the music and drink coffee, and we can talk. That is very easy. But after they come here, you know, every doctor begin the study, they need to come to Chongqing and finish 2 weeks study. And they always told me it's very difficult. It's much difficult than do surgery. I told them, yeah, HIFU is simple, but HIFU also is very difficult. Why? Because when we do surgery, we can see everything just in front of us. But when we do HIFU, we just through the screen. So the image you can figure out is very important. That means you should know the ultrasound. You know the ultrasound very good. But also the clinical skills is very important. You must know the picture. You must know the relationship of the body. This is very important. And also for HIFU treatment patients, you must need patience. You need a lot of patience for this. And also the third one is the talking skill. Maybe surprise, because this is different. Because this is very different from surgery. You know, surgery we just cut the bone outside, and you know we all have the mobile phone, and we take picture, and maybe we just show this picture to the patient's family. So you see, this is your bone in your body. But HIFU, we cause necrosis, but the fibrosis is still in our body. So sometimes the patient can not understand this. The family member cannot accept it. So why I have this treatment, I still have the fibroids. So talking skill is very important, the communication.
Thank you. That's very clear. That's very clear. So back to our chairman, Professor Fong, please. Over to you.
I enjoy myself very much for this 4th episode, and I hope the rest of you too. And I think, well, it leads us to conclude this session. I'd like to thank everybody, each and all of you who have come and participated. And of course, we wish everybody a very good year end, and we look forward to seeing everybody again in the new year. Olarik, anything to conclude?
Yes, I think please stay tuned for our lecture next year. I heard that Chongqing, there is a lot of the training program for next year about the HIFU. So please stay tuned. Keep in touch.
Yes.
Okay, welcome to Chongqing.
Okay, so signing off, and goodbye to everybody. Thank you.
Professor Chi Long Lee, he's here.
Oh, okay.
And he turned on his camera. สวัสดีครับ you please say something for our participant.
Yeah, thank you for your participation. And I think that today we have achieved a lot of the achievement here, because of all of you have a very good topic, and we have learned a lot from your talk. And thank you very much for your participations. And so thank you very much. I hope the next event we will see you again. Thank you.